Colorectal cancer is a type of cancer that affects the colon or rectum. It is one of the most common types of cancer worldwide. It can cause severe harm and death. Colorectal cancer is the third most common cancer worldwide, accounting for approximately 10% of all cancer cases, and it is the leading cause of cancer-related deaths worldwide. It predominantly affects older individuals, with the majority of cases occurring in people aged 50 and above. Several lifestyle factors contribute to the development of colorectal cancer, such as high intake of processed meats and low intake of fruits and vegetables, sedentary lifestyle, obesity, smoking, and excessive alcohol consumption. Common symptoms include diarrhea, constipation, blood in the stool, abdominal pain, unexplained weight loss, fatigue, and low iron levels. Today on your favorite health TV talk show, The Physicians, we're talking about colorectal cancer, the importance of screening. Do stay tuned. Welcome back. If you are just joining us, this is your favorite health TV talk show, The Physicians, where your health is our business. My name is Dr. Memuna Yusuf Kadri, and of course, with my regular co-host.
My name is Dr. Martina Agbere. Welcome to your regular health TV talk show, The Physicians, where your health is our business. I will always be our business.
Today we are talking about colorectal cancer, the importance of screening.
Importance of screening.
When was the last time you screened for cancer?
Well, I did that actually 2 years ago. 2 years ago, I did screening for cancer 2 years ago.
Which one with cancers?
Of course, colorectal. Of course, colorectal. I did a colonoscopy.
Have you ever done colonoscopy?
You took it out of my mouth. I did a colonoscopy.
So that's a good thing for us, and they say charity begins at home. We, the co-host of The Physician, we must practice what we preach.
Because doctors usually would ask patients to go do this investigation,
and they don't
really do it.
Yeah. I'm happy you started with us, because I did my colonoscopy. It was a bit, but again, the most important thing is that doing it and the result comes out and they say, you are free. But how often is this supposed to be anyway?
Well, we have an oncologist that's coming.
That is the thing. We have an oncologist coming on board who is going to school us on colorectal cancer and, of course, the importance of screening. That is the message you want to pass across to each and every one of you today. We'll be right back after this time, and do stay tuned.
Every day and in every way, enjoy that I find support. No matter the role you play, nutrient pack supplement for you and me. In your body, that I fight you.
Darvite Nutritional Supplement is loaded with essential multivitamins, minerals, and natural ingredients that helps you to be at your best. Darvite from LB Pharma. Darvite, love yourself.
Welcome back. If you're just joining us, this is your favorite health TV talk show, The Physicians, where your health is our business. Today with us in the studio is the amazing, delectable, brilliant, working encyclopedia, no other person than the lovely Dr. TEMITOPE OLATUNJI AGUNBIADE. She's a consultant oncologist with Lagos State University Teaching Hospital. You're welcome, Doctor.
Thank you for having me.
Beautiful.
Thank you, ma'am.
Exactly. Oncologist looking like this. Yes. We have doctors now in the 21st century.
Thank you.
You're good.
Thank
but today
you.
we're talking about the importance of screening in colorectal cancer.
Yes.
But before we go into and deep dive into that importance of screening, let us know more about cancer and narrowing down to colorectal cancer specifically.
All right. So basically, cancer is a disorderly growth, or what you can say abnormal growth in cells. God has done it in such a way that when cells grow, they're supposed to grow old and die. It's a process called programmed cell death. But unfortunately, when there is cancer, there is mutation, those cells don't die. They just keep growing and taking all the nutrition at the detriment of the other part of the body. That's when you see them. They are pale. There is no blood here and there. They are tired. So the cancer cells, whatever it is that's implanted itself, is just growing and growing bigger. So let's now narrow down to colorectal cancer. All right. So colorectal cancer is the cancer that develops in the cells of a GIT system, the large intestine. It can occur anywhere around the cecum, ascending colon, transverse, descending colon, sigmoid colon, the rectum, and even sometimes the anal canal. All right, so what happens there basically is this. Those cells, they grow abnormally. Okay. And patient can present with all sorts of funny complaints and all that. They can present with unexplained weight loss, or they're saying they're having diarrhea, they're having constipation, or they're telling you, doctor, this, if you press this area, it's a bit hard, I've had it for a while and all that. Or they may even present with rectal bleeding. I mean, they may just say, I've been going to the toilet and my stool is mixed with blood. Sometimes it may even be hemorrhoids. I mean, but how do we then say it is not something sinister that is going on there? We will probe further to see what it is. If there is need to do biopsy, we'll take a biopsy and do whatever it is that we have to do. All right. So colon cancer, it's the third most common cancer. It can really be lethal. It's a leading cause of death. In 2020, it was there was an estimated rate that the new cases that we got with, they were about a little higher than 1.9 million, and there were estimated death of greater than 193,000. So it's a major, or is rather is a leading cause of death if we don't look into it. So how do we then go about this? We've talked about how the patient can present.
No, so before you talk about how the patients can present, you already talked about the possible causes, right?
Yes.
So what actually are the, let's talk about the possible causes.
The possible causes, yes.
Of having a colorectal cancer.
All right, so I will put them in three major groups, all right? The causes, or should I, another word for it is etiological factors.
Exactly,
all right?
Yes.
So you can have the environmental exposure, or you can have the genetic factor, and also you can have the inflammatory factors, all right? So the environmental exposure, I mean, you kind of mentioned a bit of them during your introduction. We have the obesity, we have the sedentary lifestyle, we have where the patients do not eat meals that are rich in fibers. I mean, intense red meat intake, low fiber diets, no vegetables, no fruits. Then smoking and alcohol, they work synergistically together. I mean, basically in even most of the cancers, you see them in cervix is there, in head and neck cancers is there. It's just basically even in breast cancer as well. So smoking, alcohol, they're really culpable. They're major risk factors that we look at. All right. So other things that are also there. We're talking about the genetic factors.
Exactly.
The genetic factors, we have the familial adenomatous polyposis, all right? And we also have the HNPCC, which is hereditary non-polyposis colon cancer, all right? So attached to that, we have several syndromes. We have the Lynch syndromes, where you see some patients, they may present with colon cancer. I have a patient I'm managing right now, she's got colon cancer, she's got endometrial cancer, she's got breast cancer.
One person?
Yes.
So
when you begin to see patients like that, you need to screen them. You want to do their genetic workup. You want to see, do they have the BRCA gene? Do they have all this HNPCC gene and all that? So, I mean, those are also other risk factors, all right? So, in also, those HNPCC patients that have them, they are the ones that they call the high risk in terms of assessment. So, when you want to screen them, you have to start earlier for them. I mean, before it used to be screening from age 50, but because of the increasing incidence of this colorectal cancer in younger age, we've started screening from 45, even 40.
No, today we are talking about the importance of screening. So let's just understand more of why cancer screening. Why is it even important? Why are we even talking about it now?
The role of screening cannot be overemphasized. You can never overemphasize it. And as a result of this, in high-income countries now, the incidence of cancer, colorectal cancer, is on the decline.
Okay, why that?
Because they are screening. They are screening culture, which is what we are trying to imbibe in our environment.
Preventive,
I mean, we're just like what we're doing right now. We're shouting it to the public public awareness, social media, that go for your screening. You know, this month of March is a month of colorectal cancer awareness, is a month of ovarian cancer awareness. You know, they all go hand in hand. I mentioned that they could coexist. When you have the Lynch syndrome, you have HNPCC and all that. So it cannot be overemphasized, because this will help us in early diagnosis and treatment of potentially curable colorectal cancer disease and precancerous lesions. Like I mentioned the polyps. Exactly. They are precancerous. If you catch it on time, you nip it in the bud, you're able to cure the disease. Even if it's already an established cancer case, early stages, you can achieve cure. All right? There are like 4 stages of cancer. We have the zero stage, the stage 1, 2, 3, 4. The 0 stages, maybe it's just tiny pre-invasive and all that. Stage 1 is just a tiny thing in that mucosa. Then stage 2 is bigger, all right, but it hasn't gone outside. Stage 3 is big. It's bigger than stage 2. Now it even has lymph node involvement. It has gone out to involve the lymph nodes that are supposed to be draining the colon, draining the bowel. And then stage 4 is when it has left that area and gone to distant organs. So you can imagine, so if we screen this patient, we'll be able to prevent this disease progression. We will prevent the progression from pre-invasive to invasive, to even to localized disease, to metastatic diseases, knowing that the overall survival rate for the early stage is about 90. You can cure. For locoregional is about 75 or thereabout. For the metastatic is about 14.
Dr. OLATUNJI.
Yes, please.
You have talked so much about this colorectal carcinoma, yes, and the risk factors also. Now, let's see if we can. Obviously, we have different types of screening methods for different cancers, right? Definitely. Since we're zeroing on colorectal carcinoma, yes, can we now talk about the tests? What screening that do we require to be able to nip this thing in the bud?
Okay. Yeah. So most of them can be asymptomatic, all right? So when we just encourage people to go for screening, and we tell them to go for colonoscopy, which is for like 5 yearly, flexible sigmoidoscopy. No, colonoscopy is 10 yearly, flexible sigmoidoscopy about 5 yearly. Then double contrast the barium enema, which also can be done every 5 years. There is a fecal occult blood that we can tell the patient to do. When we tell them to do the general test, we tell them to do the fecal occult blood, where if you see blood,
that is like yearly.
Yes, about 1 month ago, I saw a patient that did a general check in Kenya, and he came back. They said they saw blood. I said, okay, let's do colonoscopy. So thankfully, we did colonoscopy. We did not see anything. It was just hemorrhoid, like I mentioned earlier.
Okay. I like the fact that we are taking a break from this, thankfully, meaning that not all cases are bad, especially when it's immediately nipped on board, because he came back and told you, my blood, the stool. He said, no, let's go and do this further test, and then the result came out, and thankfully we got result. Let's keep a date with the physicians. Have you ever heard about colorectal cancer? And do you know the investigations that are being done? Do you have a relative? Do you have somebody in your family who has unexplained weight loss? And we don't even know the reason why is dealing with what he's doing. And if you are the type that has been taking a lot of red meat, thinking it is part of being being rich, let's hear from you. We'll be right back after this time out. Do stay tuned.
No, I don't.
Have you ever heard of the word colorectal cancer?
No, I haven't.
No?
Every day and in every way, enjoy that I find support. No matter the role you play, nutrient pack supplement for you and me. In your body, that I fight you.
Darvite nutritional supplement is loaded with essential multivitamins, minerals, and natural ingredients that helps you to be at your best. Darvite from LB Pharma. Darvite, love yourself.
Welcome back. If you are just joining us, this is your favorite health TV talk show, The Physicians, where your health is our business. Today on the show, we'll be talking about colorectal cancer, the importance of screening. At this point in time, this cannot be overemphasized because when you screen, you will be able to nip it on board, whether you have or you don't have. And if you even have the cancer, it's best because we have stages 0, 1, 2, 3, 4. And if you are at the early stages, curability can still be attained. And of course, with us in the studio is Dr. TEMITOPE OLATUNJI AGUNBIADE, a consultant oncologist with Lagos State University Teaching Hospital. And before we went on break, she was telling us the different screenings and the different years. So if you have done colonoscopy before, you can repeat it, but I'm not taking it away because I'm not an oncologist. Dr. OLATUNJI AGUNBIADE, please, let's break it down because today we are focusing on the importance of screening. Okay. So please, let's hear more.
Let me start with there are basically two categories. We have the high-risk patients, we have the average-risk patients. Okay. All right. The high-risk patients are the patients that have had their tests done and they have the hereditary non-polyposis colon gene, or the patient that have the familial adenomatous polyposis. I mean, there are tests that you go for that will tell you that this is what you have. Those ones are the ones that have other syndromes like the Lynch and all that. In those kind of patients, they can have other cancers. They have like the breast, they can have the endometrial, they can have even the bladder, all right? You can have the stomach, all right? So for those kind of patients, they are the high-risk patients. For those kind of patients, we tell them to start screening earlier. I mean, the American Cancer Society says that we should start screening with the increase in incidence of younger people having colorectal cancer. Now, they have said that we should start screening from 45. But for those patients that are in the high-risk group, we'll tell them to start screening earlier. Earlier than 45, even 40, earlier than that. Because quite frankly, I've had to manage 2 patients that are under 30. Yes.
Under 30?
Yes, under 30. There's a young man, he's a student. His mom is always coming to clinic with him. I mean, he's like 23.
So there's a family history.
Yes. So those are the high risk. I mean, you're beginning to wonder, you know that there is a genetic predisposition in his case. All right. So the average people, the average risk people, they're the one that we're talking about. The patients whose family, who had a personal history of cancer or a family history of cancer, or those kind of patients whose first degree relatives, you know, they have cancer and all that, they are also the average risk patients. So for those kind of patients, we advise that they start screening from 45. And another thing, if those kind of patients, they have relatives that are really young, that had colorectal cancer, we advise them to start screening 10 years before the age of that young fellow that got the cancer. So what investigations do we do, all right? When we tell people to go for screening is earlier, it's better to catch it early because this is what will help us and give us a good prognosis, better outcome. So what investigations do we tell them to go and do? Generally, you go for colonoscopy, we've mentioned, which is mandatory for every human being to do, all right? Because the older we get, then we are predisposed to a whole lot of things, a whole lot of cancer. The cells are undergoing wear and tear, you know, and like I mentioned at the onset that you can have cells that are supposed to die that will not die. The apoptosis, programmed cell death. Over the years, you can have mutation, things can happen. So it's always better to go for screening, to go and check. So what are the tests that we can tell them to go and do? Colonoscopy, like I mentioned.
45 years and above, from 45. There's no risk.
Yeah, exactly. All right, 45 years.
That's every 10 years.
Yeah, every 10. Colonoscopy, we'll tell them to do colonoscopy or sigmoidoscopy, all right? We tell them to do fecal occult, but I'm trying to narrow down.
Yes.
Or the double contrast barium enema, all right? Okay. We'll tell them to do the fecal occult blood. Even on the fecal occult blood, there are still more investigations to do. They do the fecal immunohistochemistry, immunohistochemical test, all right? If they are very sensitive, then they do the specific one, the fecal occult blood, all right? So we can tell them to do all those ones. Then we'll tell them to do blood works. For every stage of cancer, there is a treatment. This is what I tell my patients.
So now let's talk about the management.
The solution, way forward.
So we've heard so much about this cancer. So by management.
All right. So if a patient does screening and we do a colonoscopy, we'll take biopsy along the way, and we'll need a tissue diagnosis. We'll send it to the pathologist. I mean, by the way, cancer management is multidisciplinary. Yeah. All right.
Multidisciplinary meaning for our audience.
Multidisciplinary means, I mean, we have from different fields. Yeah. I mean, it's a multimodality, multidisciplinary management. We have pathologists who work with the nurses, we have with the oncologists, we have to work with the surgeon. So we all work together as a team. You will do your part, you do your part, I will do my part. That's the essence of doing a multidisciplinary team management, all right? So multimodality means that, there are different types of treatment modalities. There's surgery, there's chemotherapy, there's radiotherapy, there's immunotherapy, where the body's immune system is supposed to fight against the cancer and all that. We have other targeted therapy as well. So we have hormonal therapy, so it just cuts across, you know. So what am I saying in essence? When we now see these patients, we'll tell them to do all this tests, to take a biopsy, and the pathologist sends back the result to me, all right? I will say, okay, so this is what we have. I want to do a staging investigation. I want to know the extent of this disease. Yes. Has it spread? Is it a localized disease, or is it a local regional disease, or is it a metastatic disease? So once I do my staging investigation, which includes CT scan, chest and abdominal pelvic CT scan, or MRI, or even PET, or even ultrasound scan, when maybe in areas that you really don't have all those, but you cannot see. Even some patient may even present with ascites. Wow. Yes. Some patient may present with ascites and you're worried, or even hepatomegaly and you're just worried. So, I mean, we'll do all those investigations, ultrasound scan, it picks it up, the double contrast Barion enema, it gives you a better soft tissue delineation. MRI is superior, give a better soft tissue delineation, or we do a PET. The PET will give you information about hypermetabolic activity. You pick it up as red flames when you look at the PET. That these are the areas that you have high avidity, FDG avidity, and all that. So when we pick all those patients and we have done our staging investigation, then we'll manage according to how we'll manage the stages. All right. If you say like stage 1, say we can just go in for surgery, let's remove it and do an adjuvant chemotherapy and all that. But if if it's a rectal disease, we may just say, okay, let's do surgery, or we'll just go ahead, depending on where the location of the disease is what will guide us on the kind of treatment that we do for the patient. So we may just go in and do the surgery, or if it's a situation where you have to give neoadjuvant chemotherapy, some lesions are really big, so the surgeons will send the patient to us, so kindly give neoadjuvant chemotherapy, and when after your interval images and you've done and you're sure that we're comfortable with how shrunken the disease is, and then it will be amenable to surgery, then we can send the patient back to the surgeon, then they can do the surgery, and and the patient can come back. Wow. Then if it's rectal, there is room for radiotherapy. Okay. All right, we can do either you do chemotherapy up front, or we do radiotherapy. You see even some patients, we see them with permanent colostomy. That depends on the location. I mentioned that depending on the location of a tumor. If it's a tumor that is really down there, you can't do anything, you want to relieve obstruction, they do colostomy, they put a stump and all that. Then they can go ahead and radiate and treat that area maximally, all right, with the radiation and chemotherapy. So it depends on how early patients present, then you can know what to do. The earlier they present, the better.
Dr. Olatunji AGUNBIADE. We need to bring her back. Because this is where a lot of our guests are already getting interested. Like, okay, we may not understand all this, but it's good the way she's breaking it down. Yeah. So we are hoping that when next we call you, please oblige us to come, give this information to the general public. That's why the physicians is here. Once again, thank you very much. For all our audience out there, thank you for always keeping a date with the physicians. Today we narrowed down to the importance of screening when it comes to cancer, and of course taking one of the cancers, which is colorectal cancer. And our consultant told us about those that are high risk and those that are average risk. So if you fall among the high risk, meaning family history, there are some tests she made mention of, and they are already positive, it means that people in your generation should, you know, as much as possible, immediately get to be screened. You don't have to wait, you know, for that age of 45, which is the normal average range for screening. My name is Dr. Mimuna Yusuf Kadri, and of course, till next time, remain blessed.
I just want to say thank you for coming on our program, Dr. OLATUNJI, actually a consultant oncologist. And I'm proud to be associated with you too, because you're a medical woman. She's a member of the Medical Women Association of Nigeria, Lagos State Branch. I want to say I really appreciate you for all you have been doing in the association. This is actually a voice. Being a woman and also an oncologist, the passion is actually there, and you are spreading the news. You're letting people know it's good to screen and the importance of screening. And I'm also glad M1, the medical women, are also doing the same thing. We are also here that we have. I really appreciate you. And of course, I know when we call again, please oblige us that opportunity. And to our viewers out there, I want to say thank you for being part of our program today. Remember to follow us on the social media platforms. My name remains Dr. Martina Agbemi. Till next time, stay blessed.